On this note, Mr. Chairman, permit me to invite the inaugural lecturer's friend, Professor Maxwell Udoana, to tell us a little about the inaugural lecturer. What do you use? Okay. Thank you.
The Vice Chancellor, the Deputy Vice Chancellors here present, the Registrar, other principal officers of the university, Provost of the College of Medical Sciences, and the Postgraduate College, the Chairman Committee of Deans, Deans of Faculties, Deans of Student Affairs, Directors of Institute and Directorates, distinguished professors, management of the teaching hospital here present, my lords, spiritual and temporal, heads of departments, professional colleagues of the inaugural lecturer, members of ASU, invited guests, families of the lecturers here present, members of the press, students, Malabite and Malabresis, ladies and gentlemen, please can you stand up, the inaugural lecturer. So this is a citation of Professor Victor Okon Ansa, the 125th inaugural lecturer, University of Calabar. It is a pleasure to present this citation of my friend and colleagues of over 40 years, almost 5 decades. We have been together in secondary school and in university as schoolmates. Professor Victor Ansa is a professor of medicine, University of Calabar, and Honorable Chief Consultant Physician and Cardiologist at the University of Calabar Teaching Hospital. He's a fellow of many colleges, starting from our own college and wearing a tassel, the golden tassel, that's where their faculty is, of the West African College of Physicians. He's a fellow, the Medical College of Physicians, fellow of the Royal College of Physicians of London, fellow of the European Society of Cardiology, fellow of the Nigerian Cardiac Society. He holds the postgraduate doctor of medicine degree of the National Postgraduate Medical College of Nigeria. He is the second child of Chief and Mrs. Justina Effiong Ansa, both alive and into their 80s and 90s, of Okwiboku, Akwa Ibom State. Professor Ansa completed his primary education at the Anglican CMS School in Ikorodu, Lagos in 1973. He proceeded to the prestigious Federal Government College, Ikorodu, where we met, as one of the 48 pioneer students. He actually started in 1974 because of logistics. He passed out in 1978 with Division 1 in the West African School Certificate Examination. He had a one-year stint in the same school, in the higher school program, but left in 1979 to take up a mission in the University of Benin Medical School, also where we met. He graduated with MBBS in 1985. During his undergraduate training, he was one of the federal government merit award winners. Can you clap for him? And enjoyed full scholarship throughout his studies, so the parent didn't need to pay much. He then proceeded for the one-year housemanship at the St. Luke's Hospital, Anoa, where he underwent his tutelage under the late Dr. Ann Watts, a renowned obstetrician and gynecologist, and other seasoned consultants. He did his national youth service in Guyuk local government of the then Gongola State in 1986 and completed in 1987. Owing to the excellent service he rendered, he was given immediate employment as a medical officer and posted to the General Hospital, Wukari, now in Taraba State. He worked there until 1989 when he joined the residency program in the Department of Internal Medicine at the University of Calabar Teaching Hospital. We were also moving together. He made steady progress, completed the program in April 1988, and was indeed the first to have finished that program in that department. So clap for him. He was appointed lecturer 1 in the University of Calabar in the Department of Internal Medicine in November 1998. He was appointed honorary consultant at the University of Calabar in 2000. And in the interim, he was consulting for the University of Uyo Teaching Hospital as a pioneer staff in the Department of Internal Medicine. He made steady progress in the academia and was promoted in 2011. He has published widely with focus in internal medicine and the subspecialty of cardiology. He has over 60 journal publications and some chapters in books. He is highly cited with close to 2,000 citations. He has supervised over 50 residents at membership level and 15 fellowship in dissertations in the subspecialty of cardiology, and are still counting. He had his observership in Myout Hospital in India in cardiology. Ansa went into university administration very early. In his 28 years in the service of the University of Calabar, I've always told him that he has been everything except one. You know the one he is not yet. In the University of Calabar, he has been chief. He was examination officer, head of department, substantial head of department as from acting. He has been sub-dean. He has been dean of the Faculty of Clinical Medicines. And he was also the pioneer dean when Faculty of Dentistry was established. In fact, he was holding the two posts. He became the provost in 2018 and till 2023. During this period in the college of the provost, the college experienced tremendous growth in both workforce, infrastructure, firmly positioning it as the flagship of the university. He became chairman committee of deans 2015 and 2016 session, a period that saw the creation of new faculties and programs, presentations of several inaugural lectures, approval of university sponsorship of staff for conferences, workshops, and study fellowship. He was elected into the 13th Governing Council of University of Calabar in 2022, representing the Senate, and served meritoriously in several committees. He has been chairman, member of several committees of boards, chairman, Unical Medical Center Governing Board, chairman, Faculty of Medicine Academic Board. He has been a Senate member for a long time, since 2011. He has been a central AMPC appointment and promotion of the University of Calabar since 2015 to 2023. He also served with board outside the university, management board in Neuropsychiatric Hospital, Calabar, 2018 to 2023, management board, University of Calabar, Teaching Hospital, 2018 to 2023. At the West African College of Physicians, he has cut his teeth in several of the positions there. He has been faculty chairman, he has been chief examiner where all members pass through. He has been internal assessor in the Faculty of Internal Medicine, and has also led and taken part in several accreditation exercises on behalf of the faculty. He is presently the director of training of the West African College of Physicians, the first from this part of the world. Professor Ansa is a resource person to the Medical and Dental Council of Nigeria, MDCN, and the National University Commission, among other corporate bodies. He has been external examiner to several medical schools within Nigeria and the West African sub-region. In fact, he was nominated by our college, the West African College of Physicians, as a contact person for the establishment of the East Africa and Central African Postgraduate Medical College. Can you clap for him? He widely travels and has been to almost all the countries of the world. He is a member of several bodies, Nigerian Medical Association, Medical and Dental Council Association of Nigeria, to which he was the local chairman and a NEC member. He has been a member of Nigerian Hypertension Society, Nigerian Cardiac Society, Pan-African Society of Cardiology, European Society of Cardiology, and World Heart Failure Society, which is where he has taken his lecture from. Professor Ansa is happily married to Dr. Mrs. Cornelia Amber Victor Ansa, PhD, and the union is blessed with children and many grandchildren. Madam Vice Chancellor, distinguished academics, ladies, gentlemen, Malabite and Marablesses, it is my pleasure to present to you a great teacher, a mentor to several doctors, an astute administrator, intellectual giants, provision and compassionate physician and cardiologist, a gentleman and a scholar of no mean repute, Professor Victor Okon Ansa, the 125th inaugural lecturer of the University of Calabar. He is to speak to us on the matters of the heart. All hearts matter. Cardiac dropsy, also known as heart failure. He will serve you fresh. So sit down and listen. Thank you and God bless.
Thank you very much. You're all welcome. The Vice Chancellor, University of Calabar, the Vice Chancellor, Association, Academic, Research and Collaboration, Registrar, University of Calabar, and other officers of the university, Provost, College of Medical Sciences, Chairman, Committee of Deans, Provost, College of Postgraduate Studies, Deans of Faculties, Dean of Students' Affairs, Directors of Institutes and Directorates, Distinguished Professors, Heads of Departments, especially my own Head of Department, Dr. Ofem Ena. Please give me a round of applause. You are all. My Lord, spiritual and temporal, invited guests, my dear family members, members of the press, students, Malabars and Malabresses, Malabars and Malabresses, ladies and gentlemen, I present the 125th inaugural lecture today. And I'm talking about in matters of the heart, all hearts matter. And I'm focusing on cardiac dropsy, which is same thing as heart failure, which I think is on the prowl. And I'm making a wake-up call to keep the heart healthy. This is the outline of the lecture I'm going to give today. I give glory to the Almighty God for this opportunity given to me to give the 125th inaugural lecture. This is coming a few years after my mentor gave his own, Professor Clement Odigwe. He's here with us. Please wave to the crowd, sir. Let me the Vice Chancellor of the University, our dear first Vice Chancellor, for this opportunity given to us to interact with the town. So the gown is meeting the town, and the town is meeting the gown. This lecture is aimed primarily of creating awareness about heart failure, its risk factors, and the impact it has on health and well-being. It's a poorly known syndrome, mainly overlooked. So the matter of the heart I'm discussing today is heart failure. It's important because it is the end result of most of the heart diseases. It's a very undesirable end result. But the good news is that there is a remedy. That remedy is prevention. So I will speak mainly about prevention of heart failure. I will also highlight through my contributions through research to the better understanding of heart failure and its prevention. That map you are seeing there is map of Africa. Some areas are missing. So that map is a map of sub-Saharan Africa, which is a region of the world that you can see the good, the bad, and the ugly. Right now, we are experiencing an increased prevalence of cardiovascular risk factors. In fact, we have what we call double burden of disease. Because as we improve in our socioeconomic status, because most of the countries in this region are low-income countries. A few have moved forward to become low-middle income, like Nigeria. That has not changed our status much. Hitherto, we are facing only infectious diseases like malaria, typhoid, cholera, and so on, which we are still facing. However, due to the rural-urban drift, we've experienced rapid urban development in Nigeria and many areas in sub-Saharan Africa. Because of this, most people have decided to adopt a Western lifestyle. Western lifestyle. They've started indulging in risky behaviors, smoking, consuming alcohol excessively, becoming sedentary, and so on and so forth. They've really imbibed the idea of taking Western-type diets, which are rich in sugar, rich in salt, and of course, saturated fat. That has resulted in this increased burden of cardiovascular diseases because we are still battling with the two arms of disease. We are battling with these ones, and we are battling with the communicable diseases. So we are at this center, a confused state. Nobody carries two things in the hands and climbs a tree. So there's a neglect of these emerging risk factors in favor of the previous factors, the previous diseases that we are used to. In fact, right now, you are aware that we're having epidemics or outbreaks of cholera, even up to now in Nigeria. So you can see that because of the neglect of these new risk factors, their prevalence is increasing rapidly. And there's lack of awareness about this impact of these risk factors on the heart and health and disease and the well-being. So many people are exposed to these risk factors and they are developing cardiovascular disease, which themselves are not identified on time, and most of them are going to heart failure. Now, when they develop this heart failure, they are unaware because they are ignorant. Even if they are aware, they are too poor to even access help because it's a very expensive illness to tackle. Even if they had the money, we have very weak health systems. But right now, we don't have the primary healthcare system, nor secondary healthcare system. Everybody goes to the tertiary healthcare system. Therefore, diverting their attention to what they should be doing. Now, there's poor access, late diagnosis. We are losing people. People who are affected by heart failure from various causes are becoming incapacitated and they are dying. These are avoidable deaths.
These are avoidable deaths. And who are those who are dying? Our young and middle age. In this part of the world, the young and middle age, we are losing them in droves from heart failure caused by this, our attitude, these are our new lifestyles. Now, what is heart failure? In very simple terms. So this is the town and the gown. When the heart fails, it's unable to pump enough blood to achieve its purpose of supplying oxygen and nutrients to various parts of the body. That is, in simple terms, what heart failure is. And how do we know? What are the things that make the heart to fail? Now, the volume of blood pumped out of the heart at any time is dependent on two major factors. One, the strength of contraction of the heart muscles. And two, is how well the heart relaxes to receive blood at the right time. So that you have enough blood to pump out. Those are the two major mechanisms of heart failure. And because of that, we now have two types of heart failure majorly right now, which makes diagnosis easy. When the heart is too weak to contract effectively, we have what we call heart failure with reduced ejection fraction. These terms are clearly stated in my manual there, and then I'll show them also on the screen. But when the heart is still pumping normally, but because it was too stiff to receive enough blood to pump out eventually to circulate in the body, we have what we call heart failure with preserved ejection fraction. This is shown graphically on this slide. This is normal heart. For the heart to function well, it has to be structurally and functionally normal. So if the heart is not functioning well, it will affect its structure. If the heart is not structurally normal, it will affect its function, and vice versa. This is a vicious circle. So this normal heart is normal functionally and structurally. Now, this is the heart that we say has reduced ejection fraction. You can see how big this left side of the heart is. Big and thin, thinned out walls, flabby, because of years and years of insult from these risk factors and other conditions that affect the heart. So you can see that it doesn't pump enough blood out. Even though it receives enough blood, it cannot pump out. On this side, you find the heart that is already structurally damaged, has a very thick wall, very stiff, because the nature is not only muscle you have there, you have muscle mixed with other things. So the heart is so stiff that it cannot receive enough blood to pump out. Now, the import of this is this. Before now, people wait until they are told that their heart is big before they get frightened about their heart failing. The new situation is that your heart can still look normal, can still look small on basic chest X-ray, but it has failed. So don't wait until they tell you your heart is big before you start running around looking for help. We're going to talk about the symptoms of heart failure so that you know that even if your heart size is normal, it can still fail because of this other mechanism I've just described. Now, heart failure is a life-threatening condition and has varied etiology, which we'll come to later. It affects the person. Man, the heart of the poor and the heart of the rich. So don't say because you are poor, you cannot have heart failure, or because you are young. Nobody is too young, provided you are exposed to the risk. Even those who have terminal illnesses or chronic illnesses like sickle cell, cancers, may not die from their cancer, may not die from their sickle cell, or whatever disease they are chronically dealing with. But once these risk factors are there, they may end up dying from complications of heart failure. So all hearts still matter. Once it is diagnosed, it runs a relentless course. In other words, it had better not been diagnosed. because it may not stop tormenting. It runs a relentless course until it may lead to premature death, which is what we are trying to prevent by this exercise. Medical therapies may help. They have been helping. And sometimes we add other devices. But later on, as the disease or the condition progresses, those measures may not be useful. Now, you can imagine a situation where you are spending out your time, spending out your resources. So it can be physically, emotionally, and financially exhausting. During my practice, I have seen hopes dashed. I have seen families torn apart because of heart failure. Therefore, prevention of this scourge is the only way out. Now, let's look at the term I use called Dropsy. This is a word from the Greek vocabulary, which means water, eye drops. You can find it also in French literature. Is swelling of the soft tissue due to excess fluid accumulation. This is what most people fear. Once their feet are swollen, please see the doctor. They fear that more than even the more serious symptoms of heart failure. Usually more prominent in the lower limbs. It's also called edema, which I'm sure you all know. How does it come about? These are the mechanisms of edema formation. For heart failure, the first one is the most likely mechanism. This is how the feet may look like. Sometimes not as severe as this, maybe milder than this. And in our environment, once we see this, what do we suspect? Oh, witchcraft. He has stepped on somebody's farmland. In my place, they say it's Mbiam. And they go about looking for remedies when the man is dying and only present terminally. Edema can also occur if you have other organ failures, like the kidneys, the liver, the lungs. It's not peculiar to heart failure. There are other causes of edema, which are outside what I'm talking about. Therefore, dropsy from heart failure is what I mean by cardiac dropsy. So you can have renal dropsy, you can have dropsy from liver. Now, in my search, I discovered that dropsy was mentioned in the Bible. Luke 14:1-6. Jesus Christ treated a man with dropsy. He cured a man with dropsy. And it came to pass. Went to the house of one of his chief Pharisees to eat bread on the Sabbath day, that they washed him, and behold, there's a man before him which had dropsy. Jesus Christ healed this one. But Jesus Christ is no longer with us. So don't wait. Then the same Luke 14 talked about the same thing, but it now says swelling of the body. I've said it before. Now, the swelling usually comes late. The earliest symptom of heart failure is difficult in breathing. In other words, for example, if you have been climbing this flight of stairs easily, and suddenly you discover that before you climb, you have to stop 3-4 times, please see your doctor. It may not be only heart failure causing that, but see your doctor to tell you why. Things you were doing before, even in the other room, you find yourself no longer what you used to be, and you are panting and sweating. Please see the doctor. It's unwise to wait till the feet swell before medical care is sought. What is cardiology? It's a branch of internal medicine concerned with prevention, diagnosis, and treatment of the heart and blood vessels. It has two main branches, the adult and the pediatric. My friend there, who wrote my citation, is a pediatric cardiologist. It can be invasive or non-invasive. In other words, some people have to invade your body to cure you. I'm a non-invasive cardiologist. But we have many ones who are invasive, and we call them interventional cardiologists, who use devices to save lives, apart from drugs, which we do. Now, this specialty is very special because it is a hot cake for many young physicians. It involves several years of training and retraining, both at home and offshore. It's changing rapidly with guidelines being developed day to day and new medications coming in to help us. My career has been very fulfilling during this short time of practice, the specialty. Now, these are the things we use for non-invasive cardiology. You can see ECG. I'm sure some people must have gone through one or two of these to detect some heart disease or to tell you are fine. Then these ones are used for the interventional cardiologists. Pacemaker insertion, which has saved so many lives. Those who have blockage of their coronary arteries can have this to open the vessels and allow blood to flow. So you must invade the system very minimally, and you get this balloon, and then you relieve this stent to keep the vessel open for blood to flow. You save many lives using this. There's to a large extent. These are my mentors. My guy is still there, Professor Odigwe, and others from other centers, Professor J.J. Andy, Professor Cole in Ibadan, and Mohandas in Chennai. These are my research collaborators in Canada and in South Africa. I'll leave this out and go straight to the other aspects. Now, this heart we're talking about. How much do you know about the heart? Where is your heart? Sometimes patients call me, my heart, they say, show me your heart. And they point to the wrong side, and I say, thank you. That is not where the heart is. And both of us will have peace of mind. The heart is located on the left side of the chest. It expands up to the middle and then sometimes to the right. Some people have their hearts on their right, naturally. There are very few. So sometimes we are baffled. Search for the heart here, you don't see it, you may have it on the right. And it's still normal. Now, it has 4 chambers, as you can see, and valves that take blood in and out. It's fist-like, just like a fist. It beats 100,000 times a day and pumps 5 to 6 liters of blood per minute. So in a whole day, you can pump 7,000 liters of blood around your body. This is a fantastic organ that you must not joke with. Don't joke with this organ. It is small but powerful. Now, even though it pumps out this amount of blood every day, it doesn't take its blood supply from the chamber. It has its own special blood supply from these coronary arteries that can themselves be a problem. When you indulge in all these lifestyles, you can coat these vessels with cholesterol and so on. You can be blocked, and then you require what I showed you before, the stent to open up. You can die in the process, okay? And they are called coronary vessels. They are quite intertwined and work simultaneously. Now, the heart also has what kickstarts it, like the kickstarter of the heart, is called the sinoatrial node or the pacemaker. That kickstarts the heart and sets the rate. That's why some people, when they're in love, they say, you are my pacemaker. You are my sinoatrial node. Because if that node starts beating or begins to be erratic, you'll be in trouble. So all the beats must come from the sinoatrial node, go down to the ventricles, and normal heart rate is fixed at between 60 and 100 beats per minute. Anything lower than 60 is low. Anything above 60 is high. Now, what are these risk factors? What are these factors? They are conditions or behaviors that predispose you to heart disease. Conditions or behaviors. You can see now, tension is a condition. Smoking is a behavior. This is a behavior. Excessive alcohol consumption is a behavior. This day we have happy hour. We have club hour. Be careful. Dyslipidemia, this is increased cholesterol. These ones are modifiable because you can mitigate, you can change them, you can take your drop of blood pressure and it's controlled. But these ones are non-modifiable. Age, you can't change your age, you can't change your race, you can't change your gender, even though these days people attempt to change their age or attempt to change their gender. But that doesn't prevent them from having what they should have. What are the causes of hypertension? Of heart failure? Hypertension. The commonest cause in Nigeria is hypertension. People joke with it. People don't take their dose. Poorly controlled hypertension is the one that will give you a problem. Valve diseases. If your valve is leaking, if you have a disease of the heart muscles, it can also cause heart failure. If you have a congenital heart disease, recently somebody called me that a 40, 50-year-old is still carrying around a congenital heart lesion, which could have been treated as a child. You can imagine the stress that heart has gone to in the last 40 years. So all this can be corrected. Now, drugs. We can be used for therapy and drugs that are used for recreation. Cocaine, heroin, and then infections like HIV, which you know, and so on and so forth. Now, this shows us how the heart fails. This is too scientific, so I'll just break it down. This diagram tells us that it takes a long time before the heart succumbs. Many years of struggle, okay, after being stressed by a risk factor, by a condition. For example, if you're hypertensive, you don't take your drugs, BPC high, then the heart will struggle with that for years before it fails. The heart does not want to fail if you help it. Meaning that if you mitigate those risk factors, the heart may not necessarily fail, even if they are exposed to those problems. This is also one of the things we talk about. This sleep apnea, which I didn't mention in the last slide, called sleep disordered breathing. People think that snoring is fantastic, it's dangerous, because snoring can cause heart failure in the long run. It can cause both types of heart failure, both reduced ejection fraction and can also cause the one of reserved ejection fraction. So anybody who snores should seek medical help quickly for therapy. What are the clinical features of heart failure? I've mentioned the most important one, difficulty in breathing, on exertion. Those things before now you could do without panting, you now do and you are panting, please seek medical advice. Now, let me show you briefly this particular slide. How the heart failure is staged. See this one? Stage A is stage at risk. This is now how we define heart failure universally. So all doctors in the world have agreed that this is how heart failure should be defined and staged. Stage A means that you have the risk factor. Your heart is still normal, both structurally and functionally. So if you are smoking, you're already at risk of heart failure. If you are taking alcohol excessively, you're already at risk of heart failure. If you remove that factor, you are safe. If you don't, then the pressure on the heart will continue for years until the heart fails. And I told you the heart doesn't want to fail. So don't wait until the symptoms come. Let's look at the epidemiology of heart failure. Heart failure is now a pandemic. You hear pandemic for COVID, pandemic for cholera, but you never hear of pandemic for heart failure because the awareness is very poor, especially in this part of it. It's a pandemic. It is killing people. Look at statistics. 26 billion adults worldwide are living with heart failure as of 2014, compared to 32 million living with cancer and 34 million living with HIV/AIDS. See how it is. But you all know more about HIV, you all know more about cancer, but you don't know about heart failure, which is also killing. So the fear of heart failure is the beginning of wisdom. Look at Africa, no statistics. no research to tell us how many people are living with heart failure. But thank God, we just finished a worldwide research, which I'm sure will populate data for these countries in Africa and Latin America. However, we do small studies in hospitals and clinics to give us an idea of the burden. So colleagues of mine have done some studies and discovered that if you enter a medical ward where you have medical patients, almost half of the patients you see there will be heart failure patients. Can you imagine? If you now come to the cardiac unit of the medical ward, you discover that almost 1/3 will be with heart failure, which is quite enormous. Heart failure, like I said before, has very high symptom burden and is relentless and will always lead to end-stage disease and death. In fact, data has shown that heart failure has very poor prognosis and it can be compared to advanced cancer. It is said that it is worse in terms of survival rates compared to bowel cancer, breast cancer, and prostate cancer, which you all fear. So heart failure kills more than these cancers that we fear. Who are those that die? Our young people, middle-aged, young adults are being devastated because of ignorance, poverty, and lack of access to medical care. As against those abroad where they are in their 70s and 80s, where heart failure attacks them. Gender mainstreaming. Who are those that are affected more? Well, I think it's equal, determined by what is causing the heart failure. If it's hypertension, then maybe more of the men. However, there are diseases of the heart that are peculiar to women, like the two I've mentioned now, the cardiomyopathies, like the pattern cardiomyopathy and rheumatic heart disease. Now, what is the economic cost of managing heart failure? Look at the humongous amount in the US, $20.9 billion for 2012 alone. And they think that by 2030, they will be spending $53.1 billion to treat heart failure in terms of home care, hospital admissions, doctors' fees. How much is the burden of Nigeria for 1 year? Also, no data for Africa. But like I said, maybe after our study is published, we may have data for Africa. A small study done by my colleague in Ibadan showed that in Nigeria, it will cost $319,200 to treat heart failure per year. How much is this minimum wage? So all the money in family will go to heart failure. And it's out of pocket. In the US, it's insurance. Out of pocket expenses of this amount to treat heart failure for 1 year. You want to go there? Why am I interested in heart failure? Because it's as deadly as cancer. That is my story. Why do I say so? Has very poor quality of life. Have very high mortality, which means very high death rate. Now look at the quality of life in a heart failure patient. It goes down. It never improves. Okay? It goes down until the patient is bedbound. And in between, they have crisis of exacerbation. They are admitted. Money is spent. Family is stressed. It can happen once, twice a month, thrice a month. Can you imagine how much stress family goes through by the time a patient heart failure deteriorates? They may die in the process of any of these dips you are seeing here. They may die. Okay? So you can see the kind of life they will live over years until they die. Sometimes suddenly, sometimes when they are bedbound, they now die. Despite treatment. And in an environment where the cost of treatment is so expensive now with the dollar rate, our patients can no longer afford treatment. Most of the time, I pay for my patients so they can stay alive to see me the next visit because the doctors are too expensive. Now, let me compare this to a cancer patient. This is heart failure. This black is cancer. A cancer patient, once is diagnosed early and treated, lives a fairly normal life. See the smooth life he lives until maybe it's time to die. He deteriorates and dies. Heart failure, in and out, in and out, in and out, money is spent, people are unhappy, people are quarreling. So you will hear people say, I'm a cancer survivor. You cannot hear that for heart failure patient. Which one is better? So these patients also suffer from fear of the unknown, anxiety, depression, because families are suffering. You see the wife running up and down. Just last week, I lost a patient. After the family has spent all the money, outcomes are poor in patients who are depressed because they will lose hope. They will no longer take their medications and may die. In terms of deaths, look at the statistics we have. Once heart failure is diagnosed, within 5 years, we are not being sacrosanct. It's just an estimate that within 5 years, half of them would have died. Our study will show, because we don't know the study, we will check whether it's still correct, but half of them will die within 5 years. Despite what you do. Now, if they come in advanced failure, within 1 year, 90% will have gone. Therefore, persons with heart failure have poorer outcomes than those that have cancer. That is my story. That's what I said we should be careful about heart failure. How do you treat heart failure? Many methods of treating. You can use drugs, you can use other methods, you can use surgical interventions, in extreme cases. For those that don't need drugs, we modify your lifestyle. Okay, stop smoking, moderate alcohol, and so on and so forth. Then drugs are available. Very good drugs are available now to treat heart failure, even though they are quite expensive. These are the drugs we use. Then, when you respond, you can do minimally invasive device therapy, okay, using pacemakers, using the CRT. Just about 2 months ago, we had a patient that had a CRT, and it cost his company 15 million naira. The man is very fine now, but it cost the company 15 million naira. If any of us needs that in Unica, Madam Vici, can we afford it? So prevention. In extreme cases, we recommend outright changing of the heart, cardiac transplantation. Once in this place, we had somebody who had it. We just said, okay, you don't run to India and had a transplant. And came back and was so happy with himself, was driving from Okon to Calabar and so on, and forgot that that heart needs to be cared for. And we lost him out of over happiness. Now this is the web. So you must change your lifestyle and all that. Now my research contributions to this subject. I dealt mainly with risk factor because I have interest in preventive cardiology. I started with young people, and we found that obesity was very common in young people in Calabar. We found between 2% and 4% of people between 6 and 18 years were already obese as of 2001 when this study was done. And we wonder why. Because parents are happy to see their children who are robust, and they call them Ajebota. Those days are gone. Okay, so lifestyle is important for even a young person. We start early to modify lifestyle. Okay, we now said, okay, what could be causing this increase in weight in these children? Could it be soft drinks? These drinks are not soft. They're actually called sugar sweetened drinks. Sugar sweetened drink. That's the real name for those drinks. So children were consuming a lot of these drinks, and our study found out that anybody that consumes more than 1 bottle of sugar sweetened drinks will be overweight or obese. At that time, the biggest bottle of soft drink was 350 mils. But today, we have 500, we have 1 liter, we have 2 liters. So we are not winning yet. And we found that even if they didn't have any soft drinks selling shops around the environment, they still had obesity. They could source these drinks from anywhere. Hypertension. People think it's only for the adults. No. Children can also suffer from essential hypertension. This type is a type for adults, but children are suffering now from essential hypertension, not secondary hypertension. So don't tell a child not to. Now we are now doing screening now. People will say they are too young, but I can bet you many young people right now have essential hypertension and we are managing them. So please, age is no barrier to developing essential hypertension. Now, I want to see myself and Professor Oyorita say, let us see how Unica lecturers, how much they knew about cardiovascular risk factors. And we found out that it was quite encouraging. Many knew that smoking was bad. Many knew that alcohol in excess was bad. But many didn't know that being fat at that time was bad because of, Calabar is used to fattening room and so on and so forth. We now said, okay, if you are asked now what you do about this risk factor, many said they are willing to stop smoking, but several were not willing to quit their alcohol, even though they were all educated. Now, let me jump this one and go to the studies we've done about heart failure to populate data for Africa and the poorer countries. This is the inter-CSF study. I was one of the site investigators, okay? And we did in 16 countries. And the study showed that patients in Africa were of low literacy levels. They lacked medications because of poverty. And the main cause of heart failure in Africa was hypertension, followed by ischemic heart disease. Then in terms of mortality, that is death, they found that there were more deaths recorded in Africa, followed by India. And that was found to be linked with poor quality of care and infrastructure, as well as genetics. Our last study is looking at genetics of heart failure, which is quite novel, because sometimes what we have said may not be completely right. We may have some genetic prescription for heart failure, which I'm sure we'll address in the next few years. These are the results from that study. Now, we looked at another study, which we have just concluded, the global study looking at heart failure in more countries now, 40 countries. And paper came out to see whether women are more at risk of death than men. It was found that women were less at risk of death than men, even though they were both hospitalized almost equally. Heart failure and mental health, I've discussed that. This disease is relentless and is so tasking, both financially and otherwise. Most patients go into mental health conditions. They become depressed. And it's more common in the younger patients. Of course, a young man who cannot fulfill his dreams because of heart failure will be depressed. My training role. I've been involved in training of students since 1998, mainly the clinical students, third and sixth year medical students, both classroom lectures, supervising them, clinical postings, and so on. Also involved in postgraduate medical training. In our profession, university, our training route is through training students through research training program. So we've trained quite a lot of them at various levels, and many of them are in the professorial cadre. My role in administration of the university and management role has already been said. I've been exams officer, I've been acting in the Department of Internal Medicine, I've been sub-dean, I've been dean, I've been dean of medicine, I've been chairman committee of deans, and I've been the provost. Somebody said, You have not been Vice Chancellor. I said, I have been for 2 days. Courtesy of my Oga here. He gave me 2 days to ask. Thank you, sir. Our chairman committee of the, when they all travel, he said, come and ask for me. So, in terms of community service, I've done my bit, as you can see on the board. In conclusion, Madam Vice Chancellor, heart failure is indeed on the prowl. When something is on the prowl, it means that you're not aware of it. It's ready to pounce on you. Today, I believe you are aware of this dangerous animal prowling, looking for who to devour. So, as follows, heart failure affects people of all ages, gender, race, and economic status. It may occur anybody. Whether you have a disease already in your body or not, and you're exposed to the risk factors I've mentioned, you can have heart failure. It is not very rewarding to treat heart failure because it may prolong life for a short time. Therefore, prevention. And I've said, if you are smoking, you're already at risk of heart failure. If you're taking alcohol excessively, you're already at risk. That's stage A, heart failure. You're already obese, you are stage A, heart failure, and so on and so forth. People who have risk factors, hypertension, epilepsy, should please take their treatment seriously. Don't joke with your treatment. Make sure you are controlled. Don't just follow the drug and say, I've taken my drug. No. Check whether what you're taking is effective. It's giving the result that you want to prevent heart failure and keep your heart healthy. What do I recommend? I recommend that we should train people outside internal medicine, outside cardiology, to recognize heart failure symptoms early so that they can refer appropriately. I recommend also campaign for lifestyle change, cessation of smoking. Alcohol, we say, reduce alcohol consumption, but that is semantics. It depends on the individual to tell you whether if it takes so much bottles is reduction or not. But sincerity of purpose is very important. We should improve access to health care and treatment should subsidize. Out-of-pocket expenses is killing our people. We must strengthen national health insurance scheme so that you can do what you're supposed to do to mitigate and help our populace. We should also subsidize investigations for heart failure and provide facilities for treatment in specialized cardiac centers all over the country. Government should provide funding for research, which is our domain, because we are into research now, but the money we are using for research is coming from outside the country. We're only collaborating. We cannot initiate large-scale research from our country. So we ask government to look into that. So, a stitch in time saves 9. Keep thy heart with all diligence, for out of the issues, out of it are the issues of life. Proverbs 4:23. Thank you. Very strong hearts. The one there is crying. The one in the book is crying. The first page is crying. The heart should be as strong as this. Thank you. I'll now go to my acknowledgements. I'll now go to my acknowledgements, please, briefly. According to Cesario, gratitude is only the greatest of virtues. Not only the greatest of virtues, but the parents of all of them. That's why I must pay due respect, gratitude to those who have helped me to get to where I am today. First, let me thank our dear Vice Chancellor, Professor Florence Obi, for this platform given to us to espouse, given to us to pay our debts, which I'm sure today I have tried to pay. Thank you, man. Let me thank the DVCs who are here present. My provost was on game. My dean, Faculty of Clinical Sciences, was Usan, and other deans here present, and indeed the entire college committee or community. Let me thank my dear parents who could not make it because they are old now. My dad is in his 90s, my mom is in her 80s, but they are still strong. But this Calabar road, I don't want to suffer after they've come and gone back. They sacrificed a lot to ensure that all their children have had good education. And God has blessed them with long life to see their children, they've seen their grandchildren, and they've seen their great-grandchildren. They would have loved to be here physically. Let me thank my siblings and their spouses and children, Emmanuel and his sister Ansa, Margaret and Engineer Titus, Basi and Rebecca Ansa, Idonsi and Kainde Alade, Uwana and Emmanuel Angwell, Dr. Govin Ansa, PhD, and Hannah Ansa, who are in the UK, but Godwin is here with us. Godwin, can you show your face? Angela and Raphael Onyejuba, also in the UK. All my siblings are married to people outside my domain. My father has Igbo, Edo, Cross River, everybody's in our family. So we are a mini Nigeria. Let me thank my dear wife of my youth, Dr. Mrs. Cornelia Amba Ansa, PhD. We have come a long way. Show yourself, madam. Thank you very much. We met after my youth service. She was a couple. Our children, Prosper Inaugural and Jesse Joey. My first son, Engineer Raphael Ansa, who is in Canada. Dr. Odwabo Ansa, who was inducted on Monday, thank be to God, as a medical doctor, God's will and divine. My cousins are here. They've been quite supportive. My cousin is here, Professor Okon Ansa. Please, sir. Former DVC, Bishop Uyo. He was here before. He left Calabar to go to Uyo and became DVC there. Younger brother who should have been here, Engineer Utobasi Ansa, Director of Works in Virtue of Uyo, couldn't make it. Let me thank my in-laws, being led by the family head, Ndufa, Oscar. Please show your face, sir. And his dear wife. My late father-in-law, Eugene Etan Tui, and the wife who is still alive, Patricia Tui. Thank you for allowing me to marry your daughter at that time, because I was just a struggling young doctor. But today it has paid off immensely. I appreciate all the siblings of my dear wife, Pastor Tueta, my wife's twin sister. She's here, man. Are you here? When you see her, you will see my wife. But yesterday, people were always going to talk to her, thinking that she was my wife. Dorothy and Pastor Yama and their children, Agbo and Theophilus, Comrade Akem and Manyon Tue and Maureen. Marie-Ban and Maga, you here? Is not here. I was privileged to be one of the 48 pioneer students of Federal Government College in Cardiologist. Are you here? Pro-Unitate. You are welcome. We had an erudite Irish principal of blessed memory, Mr. Brian Kimmett. We also have well-trained teachers. In fact, we lack nothing but just to read. So I thank the federal government of that time for giving me opportunity. My medical school was the prestigious University of Benin, where I had some role models, Professor Victor Oviasu and Professor Austin Abasonwa, who were both physicians and cardiologists. In fact, they kindled my interest as a medical student in cardiology. Let me thank my trainers here in Calabar. during my provided training, the fellowship training, Professor J.J. Andy, Professor Clement Odigwe, Professor Manuel Nachi, late Professor Roland Essing, Professor Kobina Imanaga, they did their best to take us through those turbulent years of residency. Let me give special mention to Professor Odigwe. Please, can you rise, sir? I benefited immensely from his direct supervision as he guided me through my training and practice of cardiology selflessly. He didn't fail to provide me the necessary opportunities for growth. If you look at those pictures that were displayed, you see that he was always there. Whether I'm in Nigeria or abroad, he will carry me and say, come, Ansa, carry your wife, let's travel. Thank you, sir. My co-travelers in the program, it was not easy, I salute you. Some are here today. Professor Okon, are you here? Peter Peters, Professor Kevin Peters, please rise. Professor Nemo Akbar. So we came in together. This is Professor of Expressive Medicine, former CMD of Oyo, and former Provost of Oyo. My HOD of eminent doctor, Professor of Medicine. Where are you? Wave. This young man has been extremely supportive. He does not joke with me, amongst others. Let me quickly thank Dr. Idon. Is she here? And the UO team. Where are you? The UO team. They are here. Those are my mentees. She was my first mentee. She's the HOD of UO Department of Medicine. God bless you all. Dr. Fia from Umuahi, are you here? And then all my mentees in this hall, please rise and wave. There are many. Let me thank Dr. Mrs. Franca Odigwe, who is the wife of my mentor, Dr. Daniel Topa, Dr. Joe Dawson, who were chairs of my planning committee. Others are Dr. Estella Ohio, Dr. Ido Ukwe, Dr. Simon Ozoma, Bernard Akpo, Dr. Patrick Rumbo, Dr. Henry Ekpenyong, Dr. Goludo, Dr. James Agbo, and all others who I cannot mention, both here and abroad. In fact, my mentees are all watching this all over the world, as well as my classmates who are all over the world. Still, they must join us in this. Let me thank my parish priests before I forget. Reverend Father Lieutenant Colonel Magnus Kinika, please rise. Lieutenant Colonel Reverend Father. And my CMO members who are here. Let me thank the present members of the Aquarium community who have come out to Professor and their spouses and all our staff. I appreciate all of you. Finally, my esteemed family and friends who consider worldwide to join me today. Let me not forget to thank Director of Human Resources, Mr. Moses Obule, and all the staff of that division for making this day a reality. Let me thank also some of the information units before I'm crucified, and Mr. Ahi, who coordinates this center. Finally, let me thank all the persons with heart failure who have come under my care, who assisted me in one way or the other in my research endeavors. I salute and appreciate you all. Thank you very much. And may God grant you all journey mercies as we travel back to your various places. I'm sorry, I could not mention everybody. You are all recognized. And I thank my colleagues in the red gown from other faculties who are here to share with us today. Thank you very much. Okay.
If I want everybody listening with our attention and indication that this lecture has really touched our hearts. Of course, the sensitization will start here and now. And so I would want you to turn to somebody and say, please, your heart matters. The monograph.
Vice Chancellor, man. Thank you, man. I present to you the monograph of my inaugural lecture. Thank you very much.
On behalf of the University of Calabar placement, staff and students, I present to you the memento for keeps to show visitors, friends, well-wishers that you remain the 125th inaugural lecturer of this great University of Arts. Congratulations.
Thank you.